This is Agitation and Anxiety with Dr. Alan Fung. Dr. Alan Fung is a psychiatrist for the North York General Hospital at NYGH Multidisciplinary Huntington's Disease Clinic in Toronto, as well as the NYGH site principal investigator for the Enroll HD study. He is a faculty member at the University of Toronto Telemetry Faculty of Medicine and the collaborative program in neuroscience, as well as a research professor at Tyndale University in Toronto. He is a distinguished fellow of the American Psychiatric Association. This session explores the impacts of anxiety and agitation and strategies for care in HD. Dr. Fung, over to you.
Thank you very much for the kind invitation to be with all of you today. And now I know in the program, it says, the session will be focusing on anxiety and agitation, but I've decided to make it a little bit broader to cover, other behavioral, psychiatric, neuropsychiatric symptoms as well, but we can, depending on people's, interest, we can focus on agitation, anxiety, or, any particular topic. Now, can people hear me okay? Yes. Okay. Right. So, so before we begin, it says here, getting to know you, because everyone seems normal until you get to know them. So I just want to get to know people a bit better. So first of all, hands up if you can sit through a 1 hour and 10-minute lecture and you can still focus for the whole time. Please hands up. Okay. I see my colleagues from Norfolk General, several hands from there. That's why they're at the clinic, right? They have super human attention. Yeah, most people cannot focus, for an hour and 10 minutes. So hopefully I'm not the only one talking, until 12:30. I would appreciate, input, from all of you. Now, second, I was just wondering, has anyone seen this guide or booklet? Hands up if you have. I just want to get a sense. Okay, perfect. Around maybe a third people who've seen this. A carer's guide for Huntington's disease, published by the Huntington Society of Canada. Highly recommended. Anyone has seen this book, A Physician's Guide to the Management of Huntington's Disease? Again, around, a third, 40% of people. So a lot of the things are really, most of the things I'm going to talk about will be covered in this guide, and the guide would cover much more. So this is actually a very helpful resource, not just for physicians. It's something that I would recommend everybody to actually, because you can actually download an e-copy for free from the internet. So please give a copy of that to your physicians, to your healthcare providers. Okay. Lastly, before I begin formally, hands up if anyone has seen any behavioral issues in HD in anyone. Okay. And can people name some of the behavioral psychiatric issues that you've seen in someone with HD? Yeah. Frustration? Yeah. Yeah. Easily getting angered, irritable. Yeah. Emotional swings. Yep. Fluctuations. Schizophrenia. Yeah. More broadly, psychosis. Yes. Yeah. We'll talk more about that. Yep. Apathy. Extremely common. Extremely common. Hallucinations. Yes. Yep. Absolutely. Yeah. So we'll be touching on that as well. Extremely common. So lesser known, but extremely common. And perseveration. So perseveration, or what some people may call obsessive compulsive symptoms. Yeah. So we'll be talking about that. Any other? Sorry. Panic attacks. Yes. Panic attacks. Anxiety issues in general. Yep. Choking. Right. So certainly choking would be part of Huntington's. Not something that I'm going to focus on today, because it would be more along the motor symptoms, but certainly, yeah, choking, happen. Yeah, depression. Yes, absolutely. Yeah. Yes, exactly. Fantastic. You guys have really covered, all of the things I'm going to say, so excellent. Yeah, so over the next hour or so, we'll review, the symptoms of Huntington's overall, focusing on the psychiatric behavioral aspect. We'll review, some of the treatments for the psychiatric symptoms. We'll briefly touch upon the multidisciplinary team model in HD care, and I'll highlight some resources. But the most important part, I think, is time for discussion. Okay, so let's briefly, talk about Huntington's. Nothing that you guys don't know, but just want to highlight that the disease is named after George Huntington, who first actually reported on this condition. At that time, it was on chorea. So in the beginning, it was reported as pretty much a motor or movement disorder, but now we know that it's not just a movement disorder. So, I think most of you would know that it's a slowly progressive neurodegenerative disorder of slow onset. And the main pathology is in what we call the basal ganglia. So these are brain cells deep in the brain, and that part controls movements, emotions, and cognitive ability. And that's why you see all three aspects affected in Huntington's. More specifically, these structures, caudate and putamen in the brain, they degenerate. So it just shows you where the basal ganglia structure is in the brain. And as you know, is caused by the Huntington's gene in chromosome 4. Yeah, I'm not going to go into the details because you've heard from many other speakers on this information. Just to say that the pathology is due to the neurons of people with Huntington's accumulating clumps of proteins that become toxic and leading to cell death. And some patients may lose more than a quarter of their brain cells before they die, unfortunately. So just to show you the degeneration or the atrophy of the caudate and putamen. So that's people who don't have Huntington's to control. You can see that a lot of the caudate and putamen, they have degenerated.
Excuse me.
Yes.
And what are they?
Yeah. So just think of them as structures deep in the brain, deep down in the brain. In a part called the basal ganglia. Yeah. So they have degenerated. Yeah. So showing similar things, and so so whenever we think of Huntington's, we think of three domains of symptoms: motor symptoms, cognitive symptoms, and the behavioral/psychiatric symptoms. So for the motor symptoms, there are the chorias, dystonia, eye movement changes, clumsiness, things like that. I'm not going to focus on these today. Cognitive symptoms, they can range from memory loss, executive functioning loss. So executive functioning would be skills that people would need to make day-to-day decisions. So organizing information or making decisions might become very difficult in people with Huntington's. Visual motor skills might be affected. And in Huntington's, the kind of cognitive issues that we see is what we call subcortical dementia versus, the cortical dementia would be what you see in Alzheimer's, for example. So the cognitive issues in Huntington's often would be a retrieval problem rather than an encoding problem. All that means is that in a lot of people with Huntington's, the information is still there, but it's problem accessing the information. Rather than in Alzheimer's, a lot of times, the information is actually not there. Okay, so the focus is on the psychiatric features. So I've listed some of the most common ones. So depression, I've added sleep problems here because it's very common, and the sleep issues can actually affect other psychiatric features. Definitely anxiety would be very common. Obsessive compulsive features or perseveration, very common. Irritability, agitation, very common. Apathy, Mania, it can happen, but not very common. Psychosis, not uncommon, I would say. Okay, so we'll go through each one. Again, what I'm talking about will mostly be covering this guide. Now, before I go into the specific symptoms, yes. Okay, so we'll touch on that. So we'll touch on that in the discussion period. Yeah. Okay. So I just want to mention that broadly speaking, when we think about management of the psychiatric or behavioral features, it's not just medication. Okay, we try to think a bit more broadly. So this is what we call a biopsychosocial cultural spiritual model. So we want to address these different aspects. And then within each of these aspects, we try to think about 4 areas of factors. So predisposing factors, precipitating factors, perpetuating factors, and protecting factors. So when we try to come up with a management plan for our patients, we are kind of thinking of the grid. And sometimes, it can be very complicated. So this is, one figure taken from a paper illustrating how the biopsychosocial factors might interact and how the management plan might need to address all of them. Okay, so when we think about biological management, what are we talking about? Of course, medications could be part of that. And there are many different types of medications being used to treat psychiatric symptoms. So there are the antidepressants, antipsychotics, anxiety medications, things like that. And then some of the treatments for the movement symptoms can also help with some of the psychiatric symptoms. Exercising actually is extremely important as a biological treatment, and also things like meditation, relaxation, things like that. Another figure illustrating, the complex interplay of the different areas. Psychological management, so it can range from psychoeducation about Huntington's to different types of psychotherapy or talk therapy. And the talk therapy can be carried out in different ways, individual versus family, individual versus group. It can be professionally conducted versus self-help, and many different approaches to the therapy as well. Of course, the Huntington Society is extremely important part of the psychosocial support as well. And the information that they publish, would be part of this as well. And then when we think about sociocultural management, having a regular routine in people, functional activities, whether it's work or volunteering, social interactions, extremely important. And then for many patients, addressing the basics, housing, finance, family relationships, these are all extremely important. Again, nothing you don't know, but I want to highlight them, because sometimes we might overlook, when we think about what might be helpful for some of these psychiatric or behavioral symptoms. Getting social work colleagues involved, having cultural sensitivity, all of these are important. And then the spiritual dimension is often overlooked as well. So we are not talking about promoting particular religion or faith practice, but it's really to encourage existing spiritual practice. And sometimes, it may even involve collaboration with clergy members. Again, I'm not saying that religion is all good or anything like that. We know there are positive, negative aspects, but certainly this is an aspect that cannot be overlooked. Okay, so let's go to the specific psychiatric features. So I've taken some of the tables from the physician's guide. So depression. Now, it's interesting that, when I ask you guys about what would be the, behavioral symptoms that you've seen, depression was almost the last one that was mentioned. So, because when you ask actually people outside the Huntington's community, what they know about psychiatric features of Huntington's. Many of them would think of depression as the first one. But I think those of us working in the Huntington's community would know that depression certainly is common, but probably things like, irritability, anxiety, obsessive compulsive symptoms, those are even more common. So in any case, so we'll start with depression for our discussion. So this is a list of some of the features that you might see in depression. Of course, you might see depressed mood. Sometimes it's not depressed mood, but irritable mood, loss of interest in doing things, and then change in the sleep, the appetite, change in the concentration, energy, having, feelings of worthlessness, guilty feelings, or even thoughts of not wanting to live, thoughts of ending their lives, social withdrawal, hopelessness, or sometimes people are actually moving much slower, what we call psychomotor retardation, or sometimes being very agitated. So these are the common symptoms seen in depression, and also how we define depression in something called the DSM. Have people heard about the DSM? Yeah, so DSM stands for Diagnostic and Statistical Manual. So it's a it's a classification of mental health disorders published by the American Psychiatric Association, currently in the 5th edition. So those are the common symptoms of depression. When we talk about treatment for depression, we go back to that biopsychosocial, cultural, spiritual model. So I've put down 4 pillars here. So medications can be helpful for some patients, but doesn't mean that everyone would need a medication. So the patients would need professional assessment. Psychotherapy often can be helpful. And when I talk about psychotherapy, it includes mindfulness practices as well. Certainly the social aspects will be important, and also the physical exercises. So in the physician's guide, they mention about some key points to think about in the treatment of depression. So avoid overinterpretation of symptoms, keeping in mind that depression is common. And it says here that, people with Huntington's might be sensitive to side effects. Start medications at a low dose and increase gradually. I would say that's actually a general principle for everybody, not just people with Huntington's. So we try to start at very low dose and go very slow. Certainly, substance use or substance misuse can be a common, what we call comorbidity, like something very common with depression. Sometimes some people might use alcohol, cannabis, marijuana, or other drugs to help with the depression, or at least, in the mind, it's helping the depression or anxiety issues. But things like alcohol or cannabis actually are depressants. So they will actually worsen the depression. Someone asked about suicide. Certainly, unfortunately, suicide thoughts and suicide attempts, they do happen in Huntington's. So as professionals, we would actually ask patients every time about any thoughts of wanting to harm themselves. Sometimes, actually, sometimes family members get concerned that, why, there's no concern of suicide, why are we asking about that? So the thinking is, we never know. If we don't ask, people may not tell us. If we ask, we are providing a platform for people who do have these thoughts to talk about that. Yeah, so pardon us, we have to, it's our professional obligation to ask about any self-harm thoughts really every time. Now, so let's talk a bit about medications. Now, I'm not going to turn you guys into pharmacologists, but at least, because some of you might have heard about some of these medications. So the most common category of medications used for treating depression is the SSRI medications. Have people heard about some of these medications? Yeah. So I should mention that these medications are not just for depression. They are being used for depression, irritability or agitation, as well as anxiety. Okay, so the three areas: depression, irritability, and anxiety. These medications can be helpful. So the common ones being used: escitalopram, Cipralex, very commonly being used. Sertraline, Zoloft, also very commonly being used. The other ones, you might see that, being used as well. Now, there are some variations of the SSRI medication. So these medications are called the SNRI. So you can just think of them as very similar to the SSRI medications, venlafaxine, duloxetine. Yeah, duloxetine sometimes is being used for people who have both depression and low energy level, or depression with pain issues. Because in some patients, the duloxetine actually can help with pain as well. So these medications, they mainly work on a brain chemical called serotonin. Have people heard about serotonin? Okay, yeah. So again, not turning into neuroscientists, but so these are two brain cells. So we call a brain cell neuron. So serotonin is one of the brain chemicals being used to transmit information from one brain cell to another brain cell. Okay, so basically, when people are using these medications, they have more serotonin available for the body, and the net effect is that people will become less depressed, less irritable, less anxious. Now, so a natural question that people have is, can I do a blood test to measure my serotonin level? Like that's a very common question that we get. So we tell people that clinically, we don't actually have such a blood test, and we actually don't need a blood test to measure the serotonin level. Diagnosing depression, irritability, anxiety would be by clinical assessment. Okay, so I want to get that point across. But we know that these medications that work through the serotonin system will help with depression, irritability, and anxiety. There are other types of medications for the mood issues. So bupropion or Wellbutrin is one that doesn't work on the serotonin system, but often being used as well. Have people heard of that medication, bupropion? Yeah. So usually that medication is being used as an adjunct to a medication that's working on the serotonin system, but the bupropion works on some other brain chemicals, mainly dopamine and something called norepinephrine. So the net effect is this medication can help to boost concentration and interest level. Why is that important? Unfortunately, concentration problems, cognitive problems are common in Huntington's, and we don't have very good treatments. So this medication is often being used as an attempt to boost the concentration and interest in people, to address the cognitive issues and even the apathy. Certainly not perfect, but in some people, it may provide some relief. Mirtazapine is another medication that also works on the serotonin system, but it's not an SSRI medication. This medication has pretty mild effect on mood, but it's very good for sleep. So sometimes when people have sleep issues with the mood issues or with anxiety issues, we use this medication, mirtazapine. The other good thing about this medication, mirtazapine, is it may increase the appetite. So as people know, people with Huntington's are prone to weight loss. So this medication is sometimes being used to help with the weight loss issue as well. Okay. Again, you don't need to know all the details, but at least keep these names in mind. There are some older medications that may still be used in some patients. For example, these medications, they are called tricyclic antidepressants. So basically, they have the older medications being used for treating the depression, anxiety issues. Nowadays, for the most part, they're not being used, but sometimes, you might still see some of them being used. For example, nortriptyline or even amitriptyline sometimes is being prescribed by actually neurologists for pain or headache issues. So that so those are some medications that people might still see. In the physician's guide, they have more details about the medications and the dose range, starting dose being used. Now, so common question about these medications. Number one, are these addictive? So answer, they are not addictive, okay? So these medications I mentioned, none of them is addictive. Second question, do people need to take these medications for life? Okay, very common question. So what we tell people is that we don't think about taking for life, At the same time, these are not medications that people take only for a few days or a few weeks or even a few months, because it actually takes around 6 to 8 weeks for these medications to kick in the first place. And second, most people would need to take these medications for at least 6 to 12 months, to really see the benefit. So for most patients, they will be taking these medications for probably, at least a year or 2 years or a couple of years, but it doesn't mean that they need to take them for life. It would depend on whether they are benefiting from the medications, whether they're getting side effects from the medications, and then we weigh the pros and cons of the medications. Now, what are some common side effects from these medications? So there are several types of common side effects. So the most common type of side effects from these medications is actually gastric upset. So when I say gastric upset, so that can be diarrhea, stomachache, bloating sensation, nausea, things like that. Not everyone will get these side effects, but some people, would get that. So we ask people to take these medications after having a meal. And usually we ask people to take these medications in the morning because a lot of times these medications may affect sleep. So we try to ask people to take it as far away from the sleep as possible. So after breakfast, is the time when we ask people to take these medications. The second common type of side effects that people might get would be sexual side effects. Lower libido, sexual dysfunction, certainly those can happen as well. So I mentioned about these because sometimes people actually embarrassed to talk about the sexual side effects, so I just want to, put it out there. Sexual side effects can be common with some of these medications. So for people, who are experiencing these issues, definitely, let the prescribing physician know. Okay. So medications, they could be important, but definitely would not be the complete treatment. I mentioned about psychotherapy. So there are many different types of psychotherapy that can be helpful for depression. Have people heard about cognitive behavioral therapy? Yes. CBT. So it's a first-line treatment for depression, anxiety issues, and many other issues. CBT is unlike the traditional talk therapy, is kind of like learning a new approach to think about things. The idea behind cognitive behavioral therapy is the way how we think would affect how we feel. So sometimes certain what we call maladaptive way of thinking may lead to negative mood. So the idea of CBT is to try to help people to identify these maladaptive way of thinking and try to modify them so that hopefully we can modify their negative mood. Okay. And then there are different types of psychotherapy. So supportive therapy or psychodynamic therapy would be closer to what people might conceptualize as a traditional talk therapy. Yeah, but most people are not lying on the couch, when they're having therapy, right? They'll be sitting up, right? Just like seeing your family doctor. Yeah. And then, as I mentioned before, therapy can be conducted in individual setting or group setting or couple settings. There are also self-help books. This book called Mind Over Mood is a very commonly used self-help book using a cognitive behavioral approach. So there are also self-help books for mindfulness as well. So are people familiar with the concept of mindfulness? So mindfulness basically is focusing on the present moment rather than the past or the future. If you focus too much on your past, you might feel upset, angry, sad about what had happened or not happened in the past. If you focus too much on the future, you might get very worried about the uncertainties. So we ask people to focus on the present moment. So there are different types of treatments that has integrated mindfulness. So for example, mindfulness-based stress reduction, mindfulness-based cognitive therapy are some examples of formal treatments for depression, anxiety issues that have integrated mindfulness. Self-help books, this is one example, a mindfulness-based stress reduction workbook. Okay, I mentioned about social interactions, being very important. So peer support group, volunteering, interest classes, all those are very helpful for depression and other things. I want to emphasize again the importance of physical exercises, okay? And we all know that physical exercising is important, but in Huntington's, many of us working in the field would think that it may help modifying the progression of Huntington's as well. So extremely important. Now, so I also want to mention about this topic, electroconvulsive therapy, ECT. Have people heard about ECT? Now, it's also known as shock therapy. So when people hear about that term, they might have these pictures in their mind. So yeah, certainly we don't ask people to put the finger in the socket like that for shock therapy. Nowadays, so it's actually a very humane procedure. Okay, you see the electrodes are like that, and then they are just placed on the scalp of the person. Really nothing invasive. And the idea is electroconvulsive therapy is a very effective treatment for severe mood disorder. Okay, whether it's severe depression, severe suicidal ideation, or mania and other severe mood disorders. So it's being used kind of as a last resort when people have tried different medications and other treatments and have not have full recovery. So I just want to put it out there as something to keep in mind. Again, the physician's guide, will have more details and also on the different types of medications being used. Okay, so let's go to the next topic. Yes. 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 Great question. Yep. Excellent question. So the question is RTMS, transcranial magnetic stimulation, is that actually helpful for depression? So there is growing evidence of the effectiveness of RTMS. So the probably the consensus currently is RTMS could be helpful for mild to moderate depression. So for some people who may not be able to tolerate medications, or some people who don't want to take medications, the RTMS could actually be a helpful alternative. But for severe mood disorders, the evidence is actually much less for RTMS. So for severe depression, severe mood disorder, the electroconvulsive therapy is still the gold standard. Yeah. Yeah. Mm-hmm. Right. Right. Yes. Yes. So certainly, there's inequity in terms of distribution of mental health resources, including ECT. But I would say at most major hospitals, like not just psychiatric hospitals, so major general hospitals, that have mental health departments, usually they would be able to offer ECT as well. So if a particular psychiatrist is not able to offer ECT, certainly you can ask, maybe the family doctor to refer to the psychiatric department of the local hospital and see if that might be an option. Yeah. Oh, yes. Sorry. Invega Trincer. Yeah. So so that is an antipsychotic medication that is helpful for the psychosis. And sometimes for even mania as well. So we'll touch upon that in a couple of minutes. Yeah. Okay. Yeah.
One manifestation we didn't talk about is the desire to isolate oneself from friends, family, peers. I don't know which of the features that would fit in under features or whether that's
yeah, the social isolation certainly can be very common. So it could be part of decreased interest in doing things. Let me just see. Yeah. Yeah. So it can be, the loss of interest or pleasure in doing things. Yeah. But sometimes the social isolation can also be resulted from anxiety in some people. And in some people, it can be resulted from apathy. So they are not depressed or anxious, but they just appear to be not care about things. Yeah. So, okay. So let me quickly, go through the other topics and then we can have a more general discussion. So I mentioned that sleep issues are common. Here, when I talk about sleep issues, I'm mainly referring to insomnia. So when we think about sleep issues, you can think about too little sleep or poor quality sleep. So that's insomnia. Some people have too much sleep or irregular sleep-wake cycle or abnormalities during sleep, for example, breathing problems or movement problems during sleep. We don't have enough time to go to all, the sleep issues, but just keep in mind that sleep problems can actually affect behavioral or psychiatric symptoms and also the cognitive symptoms. So common causes of insomnia. So certainly mood anxiety issues can lead to insomnia, stress can lead to insomnia, inadequate sleep hygiene, meaning poor sleep habits can lead to insomnia, common things being, taking excessive naps, drinking coffee or caffeine or alcohol, too late in the day. So all those, can lead to insomnia. Conditioning is something very common for people who have chronic insomnia. So I'll give you an example. So let's say if someone who has lost a job and because of the stress, they develop sleep problems, they develop the insomnia. And then let's say after a couple of months, they found a job, they no longer have the financial pressure. So one would think that, then the sleep should improve. But the sleep problem still persists. So one possible reason for the persistence of the sleep issue, even after the person has found a job, is what we call the conditioning, meaning that when the person was having the sleep problems, when they had the stressor, the body got conditioned to poor sleep. So when they see the bed, when they see the bedroom, the body automatically became tense and they cannot relax to fall asleep. So even though the stressor is gone, that conditioning still persists. So it's a very common reason for chronic insomnia. We call that psychophysiological insomnia. The treatment for this kind of sleep problem is not sleep medication. It's actually cognitive behavioral therapy for insomnia. So I just want to mention that. There are therapists who would actually offer cognitive behavioral therapy specifically for insomnia. Substance use, alcohol is one common one that people try to use to help with the sleep, but it will actually worsen the sleep. Some medications can cause insomnia and also medical issues. Okay, just to move on. So the treatment for insomnia is to treat the underlying causes. and improve the sleep habits, sleep hygiene, cognitive behavioral therapy. I mentioned physical exercising, relaxation, mindfulness practices can be helpful. Sometimes sleep medications can be helpful as an adjunct, meaning as an additional measure. So I've listed some medications here. We probably won't have time to go through all of them, but trazodone, for example, is an example of a sleep medication that's not addictive. Okay, so a lot of the sleep medications are either addictive or they have issue of tolerance, meaning that when people use it for longer and longer, they need higher and higher dose to achieve the same effect. That's called tolerance. So many of the sleep medications have that problem. Trazodone does not have that problem. Mirtazapine, I mentioned as an antidepressant, can also be used for sleep issues, and that also does not have addiction or tolerance problem. Okay, moving on to anxiety. So anxiety is different from fear. Okay, so fear, people become fearful because there's actually some real threat at present. Usually anxiety is future oriented. People are worrying about things that have not happened. Sometimes, we call that anticipatory anxiety. So you're anticipating, the worst scenario, and you become worried about that. Anxiety is very common in Huntington's. Like different studies have reported different numbers, 34 to 61%. Sometimes the excessive worries can even lead to panic attacks. So panic attacks are pretty much intense episodes of anxiety that people may have, a lot of physical symptoms. They may have heart racing, trouble breathing. They may feel the whole body collapse, or even they may feel that they're having a heart attack. So there are both physical and psychological manifestations of anxiety. So to summarize, anxiety is overestimation of danger and underestimation of one's ability to cope with the situation. Again, when we think about how to address or treat anxiety issues, think about the 4 pillars: medications, psychotherapy, social interactions, and physical exercising. Medications-wise, is really the same medications that we talk about for depression. Okay, SSRIs or the SNRIs, or some of the other antidepressants. Now, for anxiety issues, there is an additional group of medications called the benzodiazepines. I've listed some examples there: lorazepam, clonazepam. These two are pretty commonly being prescribed. Now, these medications, the benzodiazepines, can be helpful in some situations. Okay, so for example, if someone has a panic attack, lorazepam can be a very effective way to address the panic attack quickly. Having said that, I need to emphasize that these medications, especially lorazepam, is not designed for ongoing use. Not uncommonly, people are being prescribed lorazepam for sleep issues. So lorazepam should not be prescribed for sleep issues, period. Okay, so if you know of someone who's on lorazepam for sleep issues, please ask them to talk to the doctor to figure out an alternative. So these benzodiazepines are medications, they are addictive and they have tolerance problems. So they can have roles for short-term use, but usually should not be used for long-term. Okay. There are different medications that can be used for anxiety as well, especially sometimes you might see antipsychotic medications being used for severe anxiety. For example, we'll talk more about the antipsychotics, but one of these medications is called Seroquel or quetiapine. That's something actually quite commonly prescribed for anxiety, severe anxiety and sleep issues. Okay. Again, cognitive behavioral therapy is also a first-line treatment for anxiety issues. There are self-help books for that as well. Mindfulness, again, can be helpful for anxiety issues as well. Okay. Now we're doing for time. Okay, so very quickly, these are 2 simple ways that people can do to help to calm them down. So the first one, is really a simple way to meditate. Okay, So you think of the sound of the word one, like this. One. So you just think of the sound in your mind. You don't need to hum it out, and you do that for 5 minutes. Okay, that's all you need to do. That's actually meditation. It's not something that I came up with. It's actually a Harvard professor who is a world authority. No kidding. Yeah. So so that Harvard professor, by the way, not a psychiatrist, he's actually a cardiologist. He actually came up with this idea, and he actually did some research. Being a cardiologist, being very systematic and thorough, he did some research and was able to show that something as simple as the one for 5 minutes can help people to have decreased heart rate, decreased breathing rate, decreased sweating. So people actually become more relaxed. Okay. So if you don't like the one, you can use something like Om as well. So Om. So you think of that in your mind. No, don't need to hum it. Okay. Now, so some people ask me, so why is it 1, not 2, 3, or 4? So there is really, yeah, we should maybe ask the Harvard professor, but I think there's no good reason. I think the idea is this. The Harvard professor asked people to think of the one because this is meaningless in that context. So, because if I ask you to not think about things that you're worrying about, you might think even more. But if I ask you to think about something that's meaningless, it helps to distract you. So that's how this kind of simple meditation would work. It helps to distract people. So I encourage people to maybe practice this once or twice a day, each time up to 5 minutes. Now some people would say even 5 minutes is too long. So I would tell people you can start with 1 minute. If you can do 1 minute, then you increase that to 2 minutes. And eventually, if you can do up to 5 minutes, that's great. Sometimes people would actually use this technique to help them to fall asleep as well. So, you can try that as well. Okay, so that's a simple way to meditate. The box breathing is something that people can do when they are very anxious. Now, you might already know that breathing exercises may help, with anxiety, or may help with calming yourself. So this is one way to do these breathing exercises. You take a deep breath in over 3 to 4 seconds. So 1, 2, 3, 4, and then you hold your breath 1, 2, 3, 4 before you breathe out 1, 2, 3, 4. So it's in, hold, and out, rather than just in and out. Okay, so this is like a box: in, hold, and out. That's why we call it box breathing. If you actually do 10 cycles of this, you will actually feel much calmer. So this is a technique that people can use when they feel very anxious at the moment. Certainly, there are many other techniques, that would be helpful for anxiety. I don't have time to cover them today, but these are things to get you started. One thing I also suggest to many of our patients is to list out your life priorities or bucket list, and review the bucket list regularly and act on them. It sounds like a very simple idea, but it's actually a very helpful strategy for people to gain more control over the situation. Again, social interactions and exercising can be very important. Okay, very quickly moving on to some other topics. So the obsessive compulsive symptoms of perseveration, very common. So I want to emphasize that in Huntington's, people might have this perseveration, but without what we call full-blown OCD. So they may not meet the DSM criteria for obsessive compulsive disorder, but we see these kind of features of obsessions, though, so they are kind of fixating on certain thoughts, certain ideas, certain behaviors. Very common, being reported in 10 to 50% of people in Huntington's. So it can take, different forms: counting, checking, ordering, hoarding, cleaning, things like that. Sometimes, unfortunately, it may lead to aggression. And these symptoms are also related to the degeneration of the caudate. So very quickly going on to the treatment. So for these obsessive compulsive symptoms, the treatment is actually high dose of the SSRI medications, that I mentioned. Okay, so the SSRI medications actually are not just for depression, irritability, and anxiety, but high doses of them can also help with these obsessive compulsive symptoms. Now, cognitive behavioral therapy may also help with some of these symptoms, but less effective. And I need to emphasize that despite the best treatment, it's difficult to resolve 100%. Indeed, people might say that maybe one can only expect, maybe 50 to 60% of improvement at best. Yeah, so I mentioned about, okay. So high dose SSRI medications will be the treatment. Sometimes these symptoms are so severe that we might add on some antipsychotic medications like risperidone. So risperidone is also being used commonly for the movement symptoms in Huntington's. So so these medications, risperidone or haloperidol, they are helpful for not just the movement symptoms, but they are also helpful as antipsychotics. So they can be helpful for anxiety, agitation, or these obsessive compulsive symptoms. Okay, irritability, very common again. And the irritability can start much earlier than the motor symptoms. With the irritability, that could be aggression, hostility, things like that. I would say clinically, I think that's probably the most common symptom of Huntington's in the behavioral domain. Treatments, again, medications, and the behavioral strategies. Medications, you've heard me mention 4 times already, SSRI medications. And then sometimes for severe agitation or even aggression, we might need to add on some antipsychotic medications. And in some patients, we might also need to add on the benzodiazepines. And even mood stabilizers have been mentioned. Now, so I want to highlight, other than the medications, what are some other things that might be helpful? So restructure the person's expectations and responsibilities to manage the frustration. That's common. That's actually very helpful because as people decline in the functioning, they may not have the insight that the ability is declining, and sometimes that may lead to unrealistic expectations. So helping the person to manage the expectation can be helpful. The environment should be as calm and structured as possible. Respond diplomatically, acknowledging the irritability as a symptom, not the person. So the person is not the anger or the aggression. Is a symptom. Confrontations and ultimatums should be avoided. Okay. Unless the issue is critical. Try to identify the triggers for these outbursts and redirect the person. So the key when people are having these outbursts is to try to distract them, divert their attention. And family and caretaker groups, can provide very important supports. Okay, very quickly touching upon apathy. So apathy may look like depression, but it's not depression, okay? So, of course, some people can have both depression and apathy, but very often people actually have just apathy. If you ask them, are you depressed? They're not depressed. They're totally content, actually. Yeah, but they may not be doing much. So decreased motivation, engagement, they don't care. Very common. Indeed, most patients with Huntington's may have the apathy, and it can lead to significant caregiver distress, especially when combined with the perseveration of obsessive compulsive symptoms. Unfortunately, clinically, we see quite a lot of people with this combination, the apathy with the perseveration. Yeah, very challenging situations. Coping strategies. So keeping the person busy by using different schedules or routines is important. Do not interpret the lack of activity as laziness. I would add to that, do not necessarily interpret that as depression either, because we have some families, out of very good intention, they keep saying that, you must be depressed. When the person is actually not depressed, but they are having apathy, but the family members keep saying that they're depressed, that can actually cause conflicts and distress as well. And sometimes people are actually okay to carry out the activities if they are being forced to start on the activity. So sometimes people need some encouragement in getting started. But once they're started, they may feel okay to continue. Okay. I mentioned that bupropion or Wellbutrin is sometimes being used to address the apathy, not perfectly, but in some patients it might help. In some patients, even some stimulant medications that are usually being used for treating ADHD, for example, amphetamines are being tried, as a way to address the apathy, may work for some patients. Even an antipsychotic medication called Abilify or aripiprazole is sometimes being used to try to help the apathy. Okay, mania. I'm going to actually skip over that, because even though it's being reported, it's being listed in the physician's guide, I would say clinically it's uncommon. It's very uncommon to see actual mania in Huntington's. Very often, people who might be diagnosed as having mania, in Huntington's, they may actually have extreme irritability rather than the euphoria or elated mood per se. Okay. So psychosis, I want to briefly touch upon that. So what do we mean by psychosis? So two main types of symptoms: delusions, fixed false beliefs, right? Believing police is after them, Martians after them. Delusion, hallucinations, hearing voices, or seeing things that are not there. So I put down not very common, but for example, in a psychiatric inpatient setting, is not uncommon. So I would say probably 10 to 15% of patients might actually develop psychosis. The mainstay of treatment for psychosis will be the antipsychotic medications. I mentioned that people may already be on an antipsychotic medication for their movement symptoms. So risperidone is one that's very commonly used for the movement symptoms. So people may already be on risperidone, and the risperidone can also be helpful for the psychosis. Other common ones, quetiapine, olanzapine, those are common as well. Haloperidol was very common. It's less common nowadays. It belongs to an older group of antipsychotic medications called the typical antipsychotics. Yeah, I don't have time to go into the details, but just keep in mind that the same medication can be actually used for different purposes. So ask the prescribing doctors what indications there are for each medication. Now, I mentioned before that substance use can exacerbate or can mimic certain behavioral symptoms. So it's important to ask about substance use, minimize substance use, and treat the substance use: alcohol, marijuana, cocaine, etc. Okay. Yeah, I think in the interest of time, just going to mention that as you hear from me, Huntington's disease has three major domains of symptoms: motor, cognitive, and behavioral. So it's important to have a multidisciplinary approach. So at Norfolk General Hospital in Toronto, my colleagues, in this table, we are fortunate to have, a multidisciplinary team covering these disciplines. And we've been there for 30 years. And some pictures that was taken quite a long while ago. So we have some turnover of people, but the idea is, having a multidisciplinary approach, really helps to optimize their care. So I'm just going to skip over this. Just to mention that, why do people see a psychiatrist in a Huntington's clinic? So the most common referral issues are three major areas. So management of different psychiatric issues, things that I've listed before. How to cope with HD, especially for people who have new diagnosis or people who have new onset of symptoms, and also people who want to go through HD testing, but they are not sure, so sometimes they might be referred to see a psychiatrist. Again, there are different challenges in terms of the psychiatric or psychosocial aspect of HD. And it's not just impacting the patients, but also impacting the family. So resources, again, I would just want to emphasize, the physician's guide again. There are other organizations for both patients and caregivers. Okay. And then, of course, the HD Society. Okay, so in the last, 10, 15 minutes, I just want to leave some time to address your questions. Yes, okay, yes. No problem, yeah, I can do that, yeah, okay, sure, okay, yes.
So, with something as you mentioned about apathy.
Yes.
What if somebody has like severe apathy in that, just to describe the, situation. If somebody is apathetic, doesn't leave the house, doesn't, look after themselves, like lack of showering, lack of, getting up, going out of the house, going for walks, like, how can we help those people? Like, there's lots of people where they get apathetic for a day or two, but this is like going on 2 years and trying to get them help. How can we get them help?
Great question. So the question is really in terms of how to help people, family members with severe apathy, who may not be even doing, self-care, not going out for months, years. Yeah. So, first of all, I will just say that it's challenging because treatment, at least from a medication perspective, are mostly, yeah, I would say I was used ineffective, to describe the treatment overall. So what do people do? So of course, we try what we can. So the medications, that I mentioned, whether it's the bupropion or sometimes aripiprazole or some of the stimulant medications, can be tried. Now, also, we want to treat what we can treat. So depression, anxiety issues would be much more treatable. So we want to make sure that we treat any depression or anxiety in the people who might also have apathy. Yeah, so the apathy is the part that's difficult to treat, but depression and anxiety are usually more amenable to the treatments. Yeah.
Is there a way of like breaking open the apathy, like trying to get that person to tell you something, like tell you I'm in pain or tell you that
it's
I'm really depressed or something. How can
so yeah, so the trick, the tricky thing is this. A lot of times the people, let's say, assuming that they're not depressed, not anxious, they just have apathy. It's difficult to get them to modify their behaviors because they are totally content with themselves. It's family members, people around them who are distressed. And they may not have the insight that their behaviors are affecting people around them. So that makes it very tricky because they have no motivation, or they may not have much motivation to change. In treating people with, let's say, substance use problems, we use something called motivational interview as a way to create, motivation for changes. But it's difficult to ask someone to modify their behaviors than when they don't see any reason. So, for example, I have patients or family members of patients coming in saying that they would just stay in the room, play video games for 15 hours a day. So one strategy they've tried is to turn off the internet from time to time, right? So that forces the person to come out, and it has worked, for that person. Yeah, so the person is kind of forced to come out, from time to time to join the family for activities. So yeah, so I would say it's a very challenging, situation sometimes. So I would say, family members, could keep trying, but at the same time, you want to avoid, like causing excessive conflicts, so for example, don't call the person lazy or, even depressed, right? But if they're not depressed, don't keep calling them depressed, because that may actually lead to conflicts. In severe cases, if the person is actually not even eating or anything like that, if it's actually life-threatening circumstances, then in those circumstances, we may be able to say, okay, the person's safety is being threatened, they may need involuntary hospitalization, but the threshold is very high, to involuntarily, hospitalize someone. Yeah. I don't know if my colleagues at on this table have any thoughts. Yeah. Yeah. Okay. Yeah.
Any of these concerns or family members that don't have access to a psychiatrist with that expertise, or there's a long wait to see someone with that expertise, like what are they supposed to do?
It's a tough question. I think the model that we want to use would be most psychiatrists in the community, they can actually address a lot of the psychiatric issues that we see in people. So the model that we are hoping to move towards is, people first connect with local mental health resources. And then for the additional Huntington's piece, maybe through the Huntington Society, we can build up some sort of a network that, psychiatrists, or other specialists, in the community, can connect with a specialized clinic, like our clinic, so can connect with our neurologists, psychiatrists, genetic staff on the HD specific things. Right. So I would say for a lot of the things that I mentioned about, so the SSRI medications, any doctor can prescribe them, right? So we see that, actually increasingly family doctors are getting more and more comfortable in prescribing these medications for at least depression and anxiety issues. So that can be a helpful starting point, speaking to family doctor about these issues. And then if they don't feel comfortable, often then they would make referrals. But we recognize that, in a lot of communities in Ontario or in Canada, access to psychiatrists is very limited, recognizing that. So yeah, so speaking to a family doctor, really, would be the first point. Yeah. Yes.
Doctors have disappeared.
Oh no. So this is for people on Zoom. This is a comment about in Quebec, the family doctors have unfortunately disappeared. So. Yeah. Yeah.
So you go there, every time, well, that's actually 6, and then you wait 2 hours. I don't know why the hell you got to wait, but you got an appointment. Yeah. Then you go into this little room, and you're there, and you tell madam, doctor, walks in and says, you're off, go. And the Lord is saying, whatever, go.
Yeah, so the comment relates to the challenges of accessing family doctor. Yeah. It's very true. It's so true. And at least at some point, I think the hope was that, with increasing use of like nurse practitioners, physician assistants, people, other professionals, it may help the situation. But yeah, I think we recognize that it's not ideal. Definitely. Yeah. Yeah. Yes. Yeah.
and then they'll be able to apply to say, you know, like, if you start to apply. So make sure you communicate that you're having these issues to the physician that's next.
Absolutely. Like, you know, at North General, we are blessed to have Dr. Srinivasan and Dr. Rizek, you know, who are excellent neurologists who are actually comfortable, you know, in initiating, you know, some of these psychiatric treatments. And I would say, yeah, I hope most neurologists specializing in HD would at least, you know, be able to come up with an initial management plan, you know, of these behavioral symptoms. Yeah. Yes. Yes. Oh, okay. Thank you. That's an excellent point. So the comment was related to the apathy is not. So of course, the apathy is affecting family members. One additional layer is the grief that family members might feel. You know, in a family member having apathy. So counseling to address that grief or sense of loss in family members could be helpful. Yeah. Thank you. Okay, yes.
So the CBT therapy, is it covered? Because so I've dealt with like panic attacks and depression for years, and I've actually been on Razapam for about 5. So I would like something else other than that.
Right. So the comment is about access and coverage to cognitive behavioral therapy. So yeah, it's a tough question. So for the most part, psychotherapy is not covered formally by the OHIP unless it's performed by a medical doctor. So let's say a family doctor or psychiatrist or other doctors who are performing psychotherapy that will be covered under OHIP. Having said that, I think the government has taken initiatives in broadening access to psychotherapy, so that there should be more and more places that are offering publicly funded psychotherapy services. Having said that, you know, we recognize that there are still many gaps. So unfortunately, you know, people might need to rely on insurance coverage, or you know, they pay out of pocket. Now, so for CBT specifically, there are some self-help resources. So one place is a website called a Bounce Back. So if you Google Bounce Back Ontario, you'll find a website that's a self-help website for cognitive behavioral therapy. So that may be something to get started. Yeah. Yes. Yeah.
And so my suggestion is to everybody an alternative face field. If you're contemplating with somebody that's having issues and they only say, I have a headache, and you're like, no. I've been in many doctor's appointments where I come home with a sore neck and like, how are you? And the people will say, I'm good. And I'm like, and you have to speak out. So if you are in front of a doctor somewhere, somehow, and you're not sure to ask the question, ask it about yourself. How do I deal with agitation or apathy? Just ask it about yourself, and the doctor pretty much will know that you're asking for the person you're sitting with. And I think people with Huntington's should also take somebody with you.
Yes.
I also worked in healthcare administration.
Yeah.
I go to doctor's appointments and I forget what the doctor said.
Absolutely.
Okay,
Yeah.
Go with somebody else to take notes and even write down your list of questions when you get there, because it saves time.
Absolutely. Yeah, that's a very important point I want to, you know, reinforce. Please, you know, for patient with Huntington's attending any appointments, please have a family member or someone go with them. It's important. Yeah.
Slip the list onto the doctor's desk or the table where they're going to sit. And so my husband didn't have any idea I was going to ask these questions, and I listed out all the problems on a piece of paper. and I laid it in front of the doctor.
so-
Doctor came into the room and went,
Yeah, so,
"Hey," and then he went.
Yeah.
He said, you're tripping, you're falling, you're, whatever. He went through each and every.
so the comment relates to a family member bring kind of a problem list or, kind of a summary of how the person has been doing to the doctor's appointment. Certainly that will be helpful. And please bring your medications or at least a medication list. That's something that all of us, would appreciate, because yeah. On that note, I know it's 12:34, so I would like to wrap up the formal session. I'll stay behind for a few minutes, so thank you for coming.